This is the Postgraduate Paediatric Orthopaedic video series. I'm Sattar Alshryda. I'm a pediatric orthopedic surgeon. In this video, I'll take you through the gait patterns in children with cerebral palsy, which is part of the gait analysis video series, which is part of chapter 19 of the Postgraduate Paediatric Orthopaedic book. The part 1 was delivered by Dr. Muhammad Qinawi, in which he takes us through various aspects of gait analysis and its report. Both these videos are based on the famous book by Dr. James Gait, which is the gait analysis in cerebral palsy. I strongly recommend it for the people who are really interested in treating children with cerebral palsy and interpreting gait analysis. We've seen the 5 anatomical classification of cerebral palsy. And when we talk about gait patterns recognition, this is specifically related to hemiplegic type cerebral palsy and the diaplegic type of cerebral palsy. And here we'll start with the hemiplegic cerebral palsy, in which one side of the body is affected. Gage and his colleague have identified 4 patterns of gait analysis in children with hemiplegic type cerebral palsy. In type 1, there's a weak ankle dorsiflexus. In other words, it's a foot drop. In these patients, usually there's no limitation of ankle dorsiflexion, which differentiates it from type 2, in which there's a gastrocoelius contracture, but there's no weakness of the ankle dorsiflexions. It's really important to know that type 1, if it's not treated properly, it can cause gastrocoelius contracture, and it will become difficult to differentiate between type 1 and type 2. And this is important because secondary gastrocoelius contracture in type 1, when it's treated, it does not treat the weakness of the ankle dorsiflexus, and the patient still need to wear AFO after the surgery. In type 3, the spasticity and contracture goes more proximally to the hamstring and rectus muscles, and in type 4 it will extend to the hip flexors and hip adductors. Let's start now with type 1 hemiplegic cerebral palsy, in which there is weak dorsiflexor. This is typical child with type 1. The left side is the affected side, the right side is the normal side. If you look first on the normal side, you see a nice heel strike, then flat foot, then toe off, which is not the case on the left side. If you look at the left side now, it hit the ground with the midfoot or forefoot. The first rocker has disappeared, while the second rocker started the initial contact, but it ends normally. And this is what would be visible on the kinematic charts. If you look at the kinematic chart, look in particular on the ankle one, which is the dorsiplantar flexion. You can see there's absent first rocker, normal second rocker, although its start may be late. The third rocker in type 1 is usually normal, as we can see in this arrow. However, in the swing phase, the ankle remain plantar flex, or if there's some strength in the ankle dorsiflexion, we might need to see initial dorsiflexion, but this is usually short of neutral grade. These are the main changes we see in type 1 hemiplegic cerebral palsy. However, we might be able to see some compensatory changes in either part of the lower limb, such as hyperflexion of the knee in swing phase, hyperflexion of the hip in swing phase, or pelvic posterior tilt. In this child chart, the posterior pelvic tilt is visible. However, there is no compensation in the hip on the knee. And we finish off with the treatment for type 1 hemiplegic cerebral palsy. Usually there are 3 options. Option number 1, which is the easiest, using spring leaf or hinged AFO. However, alternatives such as a TPRS and TR stimulator, which work well with very active children who doesn't want to wear spring leaf or hinge AFO. And the third line of treatment, if the extensor hallucis longus is overactive, we can do joint transfer, in which we transfer the extensor hallucis longus to the first tray. And this is usually combined with lengthening of flexor hallucis longus muscle. Now we move from type 1 hemiplegic cerebral palsy, in which there is weak dorsiflexor, into type 2 hemiplegic cerebral palsy, in which there's a short gastrocoelius muscle. This child has type 2 hemiplegic cerebral palsy. You can see there's a equinus deformity of his right ankle, and the foot always landed on the forefoot or the midfoot. And because of the equinus deformity and the ankle knee coupling, there's hyperextension of the knee on the stance face. Interestingly, his pelvic is tilted forward and his body tilted forward. And the reason why this is a compensatory mechanism, so that the center of gravity come more forward and the child doesn't fall backward. Compared to the other side where there's a heel strike, a flat foot and toe off pattern, and there's no hyperextension of the knee. And now back to the normal speed. And when we look at the kinematic charts, let's look at the ankle charts, which is the dorsiplantar flexion. You can see the foot is always in equinus through the whole cycle with a stance face or swing face. There's absent first rocker, shortened second rocker, and the third rocker, although it happened, but is shorter to compare it to the normal. And in the swing face, it is always in equinus. If you look at the knee flexion extension, in the stance face, there is hyperextension of the knee because of the ankle-knee coupling. If you look at the pelvic tilt, there's anterior pelvic tilt, and this is what I explained earlier, that the body tends to lean forward to bring the center of gravity more forward. And more subtle features, we can see there's hyperflexion of the knee in the swing face to allow some of the clearance of the foot. And also with eye of faith, you can see there's a rapid deflection of the hip in the swing face to help with the clearing of the foot as well. To finish off with the treatment, usually the treatment involves lengthening of the gastrociliary system, and this typically in a child with hemiplegic cerebral palsy means Achilles tendon lengthening. Most often the tibialis posterior is tight as well and might benefit from fractional lengthening. In early stages where there's no contractures and it's only spasticity, Botox, serial casting and physiotherapy might help. But when they reach the stage of contracture, they usually require surgery. Once this has achieved, we need to address the foot drop as we did in type 1 hemiplegic cerebral palsy. Now we move from type 2 hemiplegic cerebral palsy into type 3. In type 3, there's tightness in the gastrociliary muscles, but also there's contractures or spasticity of the hamstring and rectus muscles. These muscles act as knee flexors and knee extensors. When they are spastic or tight, they limit the movement of the knee, and this causes a problem for foot clearance. As you can see in this child, has difficulty in clearing his foot. In fact, he's scuffing the floor with his toes because the knee cannot flex as much as in type 2. Again, he lands on his foot, there's knee hyperextension, but he cannot flex his knee as much as in type 2 and had difficulty clearing the foot. Some of the children compensate by vaulting on the other side, or if they are older children, they do circumduction, which is visible on the kinematic charts in the axial and in the transverse plane. Examine the kinematic chart. If you look at the ankle, for example, it is almost similar to the type 2 hemiplegic cerebral palsy. Almost there's no ankle dorsiflexion through the whole gait cycle in the stance face or in the swing face. As far as the difference from type 2, it is the less movement in the knee and the hips. We've seen in type 2 there's more flexion both in the knee and the hip, which is not visible when there's a type 3. There are other features that help differentiating between type 3 and type 2 hemiplegic cerebral palsy. These features usually related to the compensatory mechanism that some children adopt to overcome the problem with the clearing of the foot. One mechanism is vaulting on the contralateral side. By vaulting means the child stands on the toes on the other side despite the other side is completely normal. One other mechanism, we usually see it in older children, is circumduction of the ipsilateral affected hip, and this is usually visible on the transverse plane by finding excessive abduction of the hip on that side. Treating type 3 is almost similar to type 2 treatments when it comes to the foot and ankle. However, the main difference is to balance the knee movement. There's a need to restore the knee flexion and swing phase and the knee extension and stance phase. There are several procedures that can help, including hamstring release, rectus transfer to hamstring, or hamstring transfer to rectus. Choosing the right muscles depends on many factors. However, the MG studies helps a lot in selecting the right procedure. Now we move to type 4 of hemiplegic type cerebral palsy. In type 4, there are all the features that we've seen in type 3, plus some spasticity in the hip flexors and occasionally hip adductors. Let's look at the video of this child with type 4 hemiplegic cerebral palsy. There's a equinus deformity of the left foot, and he landed on the forefoot, and the foot doesn't come to neutral through the whole gait cycle. The knee range of motion has been limited. In this child, more obvious, there is lack of full extension, but also the flexion is not full. And if you look at the hip, again the hip is limited and the hip doesn't go an extension at all. To compensate for this, the child seemed to be swinging his trunk forward and backward, and this is served two purposes. Number one, to help clearing the foot by compensating to the flexion in the knee and the hip, but also to bring the center of the gravity within the base of standing. Examine the kinematic charts and look at the ankle. For example, the ankle has been flexed through the whole gait cycle, and it range around -10 degrees and never reach neutral. Looking at the knee, on the other hand, again we look at the range of motion has been limited and seem to be flexed around 40 degrees. It doesn't reach full flexion and it doesn't reach full extension. Look at the hip, the maximum extension it reaches 0 and the flexion has been limited to 25 degrees. When we look at the pelvic tilt, on the other hand, we seem to be a lot of range of motion in the pelvis, posterior to anterior, and this is to compensate for the limited movement in the hips and the knees. And this represents the more severe type of hemiplegic cerebral palsy. Treating type 4 hemiplegic cerebral palsy has the same treatment for type 3, in which we need to correct the foot and ankle contractures, and we need to balance the muscles around the knee to give us a better flexion and extension during the gait cycle. But also we need to address the hip flexion contractures. There's a lot of similarities between iliopsoas muscles and the gastrocilius muscles. Psoas muscles across multiple joints, that's why it's more likely to get contracted in comparison to the iliacus muscle. Normally we don't need to lengthen the iliacus muscle, but we do need to lengthen the psoas muscle, and we usually do this over the brim. In non-walker, it's better to avoid lengthening the iliopsoas tendon at the lesser trochanter, because this will weaken the hip flexor. Also in type 4 hemiplegic cerebral palsy, the hip adductors are often contracted and they require relief. Now we have reached to the end of our video. We discussed the 4 patterns in hemiplegic type cerebral palsy, and these are described in the sagittal plane only. This doesn't mean that this deformity is limited to the sagittal plane, but we will see some changes in the axial and transverse plane. But putting them in the sagittal plane make it easier to understand and easier to understand the principle of the treatment. In the next video, we'll talk about the gait analysis patterns in children with diplegic cerebral palsy, and hoping by adding these information together make you better understand cerebral palsy and its treatment. At the end of this video, on the behalf of our editorial board, wish you all the best for your exam and for your practice.